is a question, I think, primarily for Stan. So I think we're all talking about there's ways to solve this, but it needs to be standard in order for it to work. And you've obviously seen standards start to the current state in healthcare. What do you think is needed, based on your experience, to get some of these things where we say we need family history standards adopted, we need genetic testing standards adopted? What do you think it'll take to actually get there?
I'm not sure. I think it probably comes down in the end to explaining to people and increasingly to patients the value of the information and what we can provide if we have the information. Because you see a lot of excitement in informaticists and geneticists around the information. But in the end, it really is patients and trying to provide high quality, individualized patient care that provides funding for the whole organization. And so I think it's a hard question. I wish I had a better answer, but I think it comes down to educating people about the possibilities that are opened if we had standards and the data could flow and be used efficiently in systems to take better care of patients.
So we have these two questions from the audience.
Yeah, I had Laura Senior from the University of Wisconsin. I just wanted to make sure we didn't miss an opportunity to also talk about the interface between private healthcare systems and public health and management of these tools for population health. And I think, Fred, I'd also like to hear your comment, because I noticed that in your data stack there, you had diet and lifestyle and environmental factors teased out as two separate kinds of data that need to be tracked and monitored. And I'm also just wondering if you guys can speak a little bit. It seems like a lot of this is downstream and targeted therapies, if there's anything about how this information could be used towards prevention and health promotion. Kind of a big bundle of questions there.
Yeah, so what's interesting is there's a couple salients in the industry right now where those are all becoming very important. So I think the emphasis around comparative effectiveness research is forcing two perspectives into the analysis. So one, more population and cohort-specific analyses themselves, and then two, again, kind of understanding the longitudinal outcome, but also so how can you create a predictive model to prevent or avert whatever downstream outcome itself. I mean, that's really, if you look at some of the PCORI projects, those are the two key things that they're looking at. So, for once, hooray for how federal government has been managing that. Greg, well played. And so, we're certainly going to see more and more emphasis on the population, but also the preventive aspects.
Can I make a comment? So, a lot of the times, I guess I have the question, what is actionable? And how do you define actionable? And what is actionable for one person may not be actionable for another. And really that does go into the preventive health. And at what point, we may not be able to treat somebody right now with a specific mutation, but is that information important for them to have? And are there some ways it can be actionable, even if it's family planning or something else that is not a traditional actionable item in the medical field?
So we got three lined up here. I guess this will be the last three questions. Now, Greg, you came a long ways, Greg. You can ask a question.
This is living, breathing data, and I think this has been a pretty good representation, although most of the breathing has been either on ventilator or agonal. And what I mean by that is that I think the piece that's missing from what we're hearing here is really sort of the individual level episodic data that really can be fed back in real time to monitor how patients are doing given a given treatment episode. And this is important for a couple of different reasons. Most importantly, it's important to make sure that the patient is being treated safely and effectively, and that they're engaged in treatment and in guiding treatment by saying, I like this, I don't like this, And we have the opportunity to do this, and there are some systems that are beginning to explore how to capture that type of data in semi-real time. And that's something different than what you were talking about, Fred, where we're having large aggregated data sets where clearly very important, but it's still more of a population approach, which is the way we've always handled medicine. As we develop data at the population level, we're forced to develop data at the population level and then apply it to individuals and hope that for this particular individual, the population level data will be informative. So I think it's important for our care to be optimized, to be able to have that type of nimble data exchange. But I think it's also going to be critically important to develop the data on evidence that some of the things we're talking about that I think we all believe are important, like family history and genomics and that sort of thing, actually work when we take them out into the real world. And again, some of the things that Josh talked about in terms of looking at, events that occur in patients that are having appropriate use of pharmacogenetic data is one way to look at that. But a lot of times we fall back on looking at process measures because they're a lot easier to measure. We don't get at the true medical outcomes. So that's something I would like to make sure that we retain as we discuss potential solutions.
Mark, the interesting thing that we've seen actually, frankly, the last few months has been kind of those organizations that curate the content, whether it's a guideline, et cetera, recognizing that, wait a minute, having the ability to have controlled collaboration around exposing our guidelines electronically, but also for us to capture back what the actual life cycle of the guideline use itself, which then allows the virtuous cycle of us to have version 2 of the guideline be much better refined, et cetera. That content companies are starting to really wake up to this. We're having some very interesting conversations around that. And it's not just kind of the professional societies or whoever creates a guideline itself, but there's plenty of health provider organizations that have to set up programs where people come and visit them and say, look, you guys take care of sepsis, congestive heart failure, better than anybody else. Can we please learn from you in some way? And those organizations are recognizing that, wait a minute, if we can package this up in terms of some kind of content bundle, then again, this is a win-win scenario. So, like I said, there's people waking up to it, and again, happy to have seen it.
If we could go through this last question really quickly, because our next panel moderator needs to leave right after his panel. So this is the last question.
All right, I'll try to make it quick, which is really hard. Larry Babb from Partners Healthcare. I'm a principal developer on the Gene Insight project, and I wanted to go back to the standards question that the gentleman asked a minute ago and propose a solution to help move along the standards. Elaine Lyon just pointed out in her presentation the work that's being done in ClinVar on that U41 grant. And it seems to me, I helped participate with Dr. Huff and a number of other people in the original implementation, fully loin qualified genetic test result, structured variants for sequence variants thing with HL7 document that we pushed through. And that was quite an effort, as you remember. It took quite a long time. And one of the things I always came away from with that was my concern was that we had a fairly small group of people trying to figure out the standard, a standard that was relatively new and early adopters, I'd say. I'd say we're very much in the early adopter phase. So I always was troubled with the fact that how can early adopters develop a standard? Doesn't a standard sort of come after the fact that something has been established and then you go and standardize it? And I understand there's this cart and horse issue. So what I think would be an interesting solution to move the standards along, which seem to be sort of stalled a little bit, is to take the work that's being done on this ClinVar grant, and there's got to be a number of top clinical geneticists contributing and collaborating. It's very interesting to observe what's going on there. They're working out the model. They're standardizing the vocabulary. They're doing things that it's just a once-in-a-lifetime kind of thing to see this come together. And to take the work that's coming out of there and then have HL7 come in and try to standardize that, use that as the model to standardize how we message and send these structured variants and sequence variants within these patient test results. It seems to me that that would give us a huge, sort of leapfrog approach versus this trickle effect of trying to add a little thing here and a little thing there. So I just wanted to propose that, see what your thoughts were.
there's a lot of work going on just to standardize some of the language. So, some labs call a pathogenic mutation deleterious, pathogenic. Is it likely pathogenic? Is it suspected pathogenic? Even things like that, if we can get those standardized, we'll be moving forward. And then standardizing the evidences of when do you classify it suspected or likely pathogenic versus pathogenic. All of those things are happening right now.
But is there a better body of people to come up with that than the ones that's established right now? I mean, I'm not going to do it with Dr. Huff and Miles. We're good, but we're not that good, Well,
the people taking the lead on that is the American College of Medical Genetics.
Right.
And you're right. I don't think
it seems like it should feed right into the HL7 work that we're trying to do to standardize these messages and whatnot. And this is sort of what I've been waiting for to happen, is to get the people that really know what to do and how to standardize this stuff to come up with what they think is right, and then for us to leverage that to help to get that out to the whole community so that we can have something that's really a standard and not, something that we're trying to force.
And Larry, I think that's going to be a great question for our breakout sessions. That's one of the issues that we want to handle in these breakout sessions and come up with conclusions there. So that concludes this panel. So thank you very much for panelists.